have eminent speakers. Dr. Vinender Singh Shiorian is a senior consultant and interventional radiologist at Medanta, the Medicity at Gurgaon, and he's a member of the Asia Pacific Vascular Society. Another great speaker is from Syria, Dr. Lou Tarazi, and he has done a massive work on male pelvic congestion syndrome. I think we'll have a lot to learn from him. And then we will have from our good friend, Dr. Denis Borsch, the vascular surgeon and the clinic of phlebology, the laser surgery, the Vascular Limited from Russia. We had a good time spent with him when we were in Moscow, and a very smart, young, bubbling gentleman, and we'll be happy to see his case presentation. We have on the chair, the master from Singapore, the Harley Street Heart and Vascular Center man, Dr. Sriram Narayan. Everybody knows him well, but we are waiting for his expert comments on this subject. And another chairperson is from the mighty mountain country, Sandeep Raj Pandey, is a consultant vascular and endovascular specialist from Kathmandu. We have on our panel, Dr. Vimalin Samuel, a senior registrar, final year MCH of vascular surgery from the CMC Vellore. And the second panelist, Dr. Lou Luthra, who is a vascular and endovascular surgery associate consultant with the surgery department, Fortis Mohali in Punjab. So dear friends, we will have now, before we start the session, I would like to share that all this has been possible due to great efforts put in by our friend company, the Servier part, and the Sardia, the India part of the Servier. So it's a pharmaceutical group governed by a non-profit foundation. Next slide, please, Vishal. And the Sardia supports brands produced in India, and our API source is from France. Next, please. They have been supporting all the healthcare professionals, and they run for the supply chain and pharmacists, the front health heroes against all the diseases. Next, please. The most important part, what Sardia has started, is the chronic venous disease awareness, because it is one of the most undiagnosed or underdiagnosed, undetected disease in India. And a patient seeks treatment when it is late in the part of the disease, but not in the early part. So this affects the quality of life and begins to limit the functioning of the lower limb. At that time, people move in, thus indicating CVD remains as an iceberg phenomenon in India. We Move, that is the page created on Facebook because we care, and that has been created by Sardia with an objective to create public awareness on chronic venous disease. Sardia has launched this page with the main aim to sensitize people about the disease and provide them with authentic and appropriate information. So we thank Sardia for this, such a beautiful move. And now we go for the talks. I invite the chairpersons to take over and invite the first speaker, Dr. Vinender Singh, to start his talk. His talk will be for 18 minutes, followed by Dr. Tarazi's talk, which will last for 20 minutes, and 8 minutes case presentation by Dennis. First, we will finish all the talks, and then we will have questions, one each from the chairpersons. And after that, we will be having an open discussion. So dear friends, try to stick to your time, and welcome Dr. Virender with your talk.
Sir, just to correct, Virender's will be 15 minutes.
15 minutes, okay. 15.
Thank you.
Sorry, I made that mistake. Vimal,
No.
Virender, you are for 15 minutes. Welcome.
Sure.
Start with your talk.
So I need to share. Somebody needs to stop. I don't have an icon for sharing.
No.
We will do that. We will do that. Don't worry.
Sir, you are a co-host. You can share your screen now.
Okay. Is it seen?
Not yet,
No.
sir.
Try
No.
again.
Vishal, you take up. Vishal, take up.
Sir, I don't have sir slide because it's so heavy.
No,
So
don't worry. Yeah, yeah. No, he will take up. Vishal, just stop your screen sharing.
sir, it's
Just
already
please.
stopped.
Okay,
No,
okay.
but I'm not having that. Okay, I got it. Okay, just a sec. I'm here.
Yeah.
Yeah.
And
Great.
sir, 1 second, I going to mute everyone and then we
Sure.
can
Yeah.
restart. Yeah.
Sure. So good evening, good afternoon.
Sir, just unmute yourself. Just click on the mic icon at the bottom.
Okay.
Yes, sir. Fine.
Vishal, and you have
Yeah,
done this
got
thing
it.
which I told you that day.
Sorry, sir. Which one?
Just before before we start, there is a miscreant in our group. There is somebody who is very naughty and he wants to spoil all the presentations by us. So we are taking some precautions here. So we have also spoken to an IG police in Delhi, and who's going to take up this matter. So Vishal,
Yes.
I hope the guy has joined.
Right, sir.
Yeah.
So now, like earlier there was annotation, like anyone can use that. So we have blocked now. So no one will be able to use the annotation.
Fine. And I hope the guy from the IT guy who has joined from the police, now he's also on the line, now.
Yes, sir. Yeah.
So yeah, okay. Guys, please don't wait because there's 6 months imprisonment and VI will not be pardoned the sorry because we have filed a criminal case last week. So please be careful. Whoever is doing it, don't do it because you will be ashamed all throughout the country.
Yeah, and
Okay.
one more thing, sir. We are like noticing this, but whoever is doing this, so this has been recording now. So yeah.
Okay, Virender, thank you.
Okay, thank you. So I will be speaking on pelvic vein reflux. So Dr. Rahul had told me to be more practical and less theoretical. So I'll be talking quickly about pelvic congestion syndrome, which is a female counterpart, and the varicocele, which is the male counterpart of pelvic reflux. So pelvic congestion syndrome is characterized by congestion of pelvic veins in women with a history of chronic pelvic vein, low backache, groin pain, paravalvular, buttock or thigh varicosities. So the symptoms are vague. Often it is diagnosis of exclusion as there is lack of awareness among medical specialties and general public. In males, it's basically called as varicocele, and it's dilatation of pampiniform venous plexus and internal spermatic vein. Well recognized cause of discomfort, heaviness, pain in testicular region, and decreased testicular function, which results into infertility. Diagnosis very easily made clinically. The patient comes with heaviness and can be diagnosed with simple test, which is duplex. So just to compare both, history for varicocele is mass, swelling, bag of worm appearance, symptoms of acute or chronic scrotal discomfort, heaviness, pain, and differing testicular sizes without palpable varicocele, and maybe an incidental finding on ultrasound. On the female side, yes, it's tough to diagnose, dragging, aching pain. The females will come with a chronic pelvic pain of 6 months duration, and can be classified as internal and external. So by internal, I mean typically pelvic pain worse on standing, lifting, deep coitus, and improved by lying supine. But then there are different presentations like groin pain, iliac fossa pain, hip pain, low back ache, and upper thigh pain. So coming to the signs, yes, there could be vulval vaginal varicosities extending to medial aspect of upper thigh, ovarian point tenderness can present as perineal buttock varicosities, hemorrhoids, varicose veins, and so on. So coming to pelvic congestion syndrome, how it is diagnosed. We all know duplex is basically a stethoscope for modern docs and can be performed trans-abdominal and trans-vaginal. In this case, a trans-vaginal ultrasound, I think, is a gold standard, and we'll learn for that. CT MR venography definitely helps. IVUS being a kind of invasive, not routinely used, but is yes, can be used and can diagnose the pathology. And then good old conventional venography, which is again reserved for therapeutic part. So coming to TVS, I think it's a gold standard, and a lot of papers have been published. Our own Dr. Whitley has written a very nice paper on that. So around the ovary and the uterus, the probe is pretty close. So you see multiple tortuous dilated veins measuring really big ones, although the studies have published that the size of the vein does not directly correlate with the symptoms, but yeah, they are dilated, seen on either side. And then there is reflux can be demonstrated with Valsalva. Patient is in 45-degree head up position, dilated arcuate veins crossing the myometrium. And then there is polycystic changes, which has been studied and has some association as well. So this is the paper. Transvaginal duplex ultrasound appears to be the gold standard. We can go over that. And the maneuver is called as hold stock. So coming to 3D MRI, MRV, and SCT venography, usually it is performed from some other reason and can give a wonderful information. This is a 3D MRI. You can see how you can study the reflux into the ovarian vein, going into the parametrial region. So this slide demonstrates the typical gold standard conventional venography. So the catheter is into the left ovarian vein, and once you take a run, you can see the cross pelvic collaterals going to the medial thigh, great reflux into internal iliacs. So this is how it looks. So I'll be going through a basically prototype case. So keeping it more practical. Yeah, management is can be medically managed initially. The patient keeps on roaming from one doc to other unless it's confirmed or it's basically a diagnosis of exclusion. Then you can do some open surgical laparoscopic ligation. Bypasses have been tried. So there are, if you read the literature, there are so many different types of approaches, even the ovarian vein to iliac bypass, and a lot of things have been tried. And then ovarian vein embolization, which is basically a minimally invasive, which I'll be talking about and which I do usually. So many ways to skin a cat. Aim is to basically occlude or stop, basically thrombose the veins which are culprit, and then basically if there is a secondary obstruction, then you need to divert or open the obstruction as well. Coming to the access, could be jugular, could be femoral. So it's operator preference. How is your cath lab orientation? Doesn't matter a lot, but if there is some deep angulation, if it's, then jugular works great. Embolic agent, again, I would say there are all types of people who have used. So you can use sclerosant, you can use liquid embolic, you can use coils, plugs, or combination of all those. So coming to look for any obstruction, what does that I mean is, this is the image from Dr. Whitley's paper. So I have given credit to him. So it shows a sagittal image which shows the pelvic network, venous network of the pelvis, and you can see how complex it is. And that's why the symptom is so varied in different patients. And when there is an obstruction, so this is basically a secondary varicosity, secondary to a cause, could be a nutcracker syndrome, which is like left renal vein compression. So it can be anterior nutcracker or a posterior nutcracker, or it can be a May-Thurner syndrome. So let's go quickly over the case. So the catheter is there into the left internal iliac vein. You have done a run, and you can see how the reflux is. So these are static images, early phase and the delayed phase. So here you can see how the reflux is going on. So in the first image, you can see the catheter is through the basically a gonadal vein, and then the second one, the catheter is through the internal iliac. So crossover, and then it goes in. So what you do is, the patient comes with vulvar varicosities. You need to treat those superficial varicosities as well. So you can see the difference in the catheters. Once you are in, so this can be divided into two settings. Go with the ovarian vein treatment in one setting and the internal iliac second, or if the symptoms are so severe, you can do both at the same time. So just wanted to share. So the catheter is inside the basically veins. You are going through the internal iliac. You have taken a run. You can see the cross pelvic collaterals, the medial thigh varicosities. So it's a coaxial system. You take your microcatheter on the contralateral side. You put some coils so that the liquid embolic or the sclerosant which you will be using should not run. And then you pull back your catheter, you block the other side, and through the coiled vein, you can easily go back with your microcatheter, and then you start injecting glue or sclerosant, whatever is your choice of material. So that's how it shows. Once this is done, you pull back, look for any other vein which is causing an issue. So you can same coil it and sclerose. So now coming back to the area which needs to be basically coiled and sclerosed. So what has been done here is, a catheter goes down, and then coaxially there is a microcatheter. We have put a coil in the mid segment of the ovarian vein, and then through the coiled part. You just take your microcatheter inside, take a good run, and here you can see a cross pelvic collateral. So microcatheter for liquid embolic or sclerosant. So you can inject a diluted glue, or you can inject a mixture of foam, lipidol, sclerosant, whatever you want to. Similarly, coming when the left side is done, and then you pack it with a coil so that everything is stasis is there, and then it gets basically thrombosed or sclerosed. So on the right side, you can sometimes from the groin, the right side cannulation is a tough part. So you can use a reverse curve catheter, or if you have a difficulty, you can come from the IJV access. So once you take a run, the same procedure is followed. You go in, coil, go distal to that, and basically put your sclerosant. So this is the initial picture. On the right side, it is basically the post embolization peak. Another case, so they just wanted to show, like when I was a fellow in States, there are different ways of doing it. So this, we have come through an IJV, go down, put a good sclerosant, and then in those times, as plugs were not freely available, we used to put a lot of coils and pack it with that. So this is how it used to look. This is another case which was done by me, but with a different technique. So the vein was really dilated. So we came in, placed a big sheet inside, took a run, demonstrated the cross pelvic collaterals, and then just inflate a balloon. And through the balloon, what you can do is, it has a good O35 lumen. You can inject a mixture of sclerosant, nicely thrombose it till the contralateral side fills. And then you can put the plug and come out. So various ways to skin the cat. This is pre on the left side and the post on the right side. Patient symptomatically definitely becomes better, and we'll be discussing about that. So coming to the male counterpart, it's basically varicocele, easily diagnosed. Even a superficial ultrasound is good enough, and good clinical examination is required. Good Valsalva, light of bulb sign is seen. I won't be going into theory part. So there are definitely indications when and when not to do it. So coming to the procedure per se, again, it's basically like a pelvic congestion syndrome, but I would say it's much simpler than that, because you don't go into the internal iliac vein. Usually all you have to do is the gonadal part. So again, treatment is operator dependent. I would say you can use coil, you can use sclerosant, you can use glue. So all three can be used. So you go into the renal vein, do a run, there is a good reflux, you can see. And then once there is a reflux, take a coaxial system, or you can just go with your diagnostic catheter down up to the inguinal ring basically, and do a good run. And then you can take a different way of treating it. You can coil it, put a sandwich sclerosant, then coil it, then sclerosant, and then another coil. You can use glue. So again, the results are great with each of the techniques. Similarly, the right side cannulation is tougher, I would say, because of the angulation. But luckily, the patients with right side reflux are much, much lesser when you compare to the one on the left side, and the bilateral are less than 10%. So again, keep your IJV prep if you are not okay with the left side. So this is basically just wanted to highlight, be aware of the anatomy. Sometimes you may encounter this secondary varicosities due to, this is nutcracker syndrome. So basically the one is the nutcracker due to compression of the aorta. The other one is the circumvallate renal vein, circumaortic, I mean, and there is a compression on the posterior part, the anterior is fine. And here you can see the aortic impression. So sometimes it is very helpful, and then you may explain your patient accordingly. So this is how it looks on ultrasound. And then once it's done, it's completely thrombosed. So this is how the picture looks immediately on day 1 post procedure. So I would like to conclude my talk by saying the success rates of percutaneous pelvic vein reflux embolizations are really good. Technically, I would say it's close to 100%, unless the vein is very tortuous or you are not able to cannulate, that's a different story, but 95% plus. Clinical success varies in male and female counterpart. In the female counterpart, it varies somewhere at max up to 70%, and after 4 or 5 years, that's my personal experience, I can say, the patient may start coming back. There is some psychological element as well. But with the male counterpart, especially the young chaps in their teens, the success rate is pretty high, 90% plus. And for infertility, it's mixed. So we have seen patient after embolization getting basically infertile and so, but the rates are not very high. The complication rate is pretty low if you do it properly. So in properly selected and screened patient, transvenous embolizations are safe and effective treatment for pelvic vein reflux, both in female and male. Thank you.
Dr. Dekivadia?
Yeah, so now, thank you very much for the talk. Now we have the second speaker, Dr. Tarazi from Syria. Over to you, Dr. Tarazi.
Yes, hi. I share screen. I am sharing screen. Do you see my screen?
Yes, sir. We can see your screen.
Yeah, we can. You have to enlarge it. Okay, it's
Okay,
clear.
We can. Good afternoon, everyone. I am so happy to be with my colleagues and friends again during this crisis. And today we'll try to be pioneers. So we'll try to speak about the male pelvic congestion syndrome. And it is the first time in the medical literature that someone is speaking about. So with my young days background, we'll try to approach it. First, does it exist really? How to identify and should it be treated and how to treat it? Sure, always looking for our work. During 18 years, we was embolizing varicocele just for infertility and not looking for pelvic congestion syndrome. But since 2 years, during last 2 years, we are searching for MPCS in every varicocele patient and in every symptomatic patient. So we have worked more. We have embolized 62 varicocele and MPCS. 18 of them was a classic infertility indication, but 45 was for other indications, other symptomatic indication. 35 of them have varicoceles. And so we have a lot of lower limbs, edema, claudication in the elderly patient, and a lot of varicose vein in the lower limbs. And we have some pelvic discomfort, dorsal pain, and sciatic pain, typical, and a lot of obstructive etiology, more than a third, and a lot of associated hemorrhoid with some urinary lithiasis, 1 hematuria, and 7 venous male impotence. So, first question, what is the relation with varicocele? Varicocele is not the totality of male pelvic congestion syndrome. Varicocele is just one manifestation of MPCS. But we like it very much because it is our best window to think and to find the male PCS. So, if we compare the male and female PCS, the male one is less frequent, is more unknown, and manifestation ambiguity, difficulty of diagnostic, more obstructive, more hemorrhoid, and less lower limb varicose vein, and less symptoms. So let's see how gonadal vein reflux seen in both sexes. In females, as you can see, it is huge varicosity in the pelvis with escape point. Here we can see inguinal, obturator, and P point at the other side. But in the males, it is more net, as we have seen in last speaker. We have just a reflux, typically reflecting spermatic vein, and we can sclerose it or do whatever we do, and there is no more reflux. So the other question, reflective or obstructive? The reflective are the same as females, but obstructive there is a lot in male patients and many pathologies. We know nutcracker. In nutcracker, the totality of the renal blood are derived to big pelvic varicosities. And with May Turner, the blood is derived to the other side via big pelvic varicosities also. And in vena cava agenesis, we know here in female how the circulation can go collaterally to the ovarian and gonadal vein, and the same thing sure in males. And in post-thrombotic syndrome, we can find huge collaterals in the pelvis to take our blood to the other side and to the inferior vena cava. So, and finally, with portal hypertension, we have two pathways. The posterior pathway comes from the inferior mesenteric artery, passing by the superior hemorrhoidal vein, vein. And the interior one is coming from the umbilical vein and passing through the auricle veins to the bladder veins and other pelvic veins. So let's have our plan. We talk about manifestation, diagnostic, treatment indication, methods, and some cases. And the first thing is a manifestation. A lot of manifestation. In the lower limb, we have the varicose veins, venous claudication, edema, sciatic pain, and here we have a lot of genitourinary manifestation with pelvic and lower dorsal discomfort, and sure we have the thrombosis of pulmonary embolism as a complication. We will focus only on some characteristic manifestation. Prostatic congestion, we noted that a lot of our patients have prostatic sign, dysuria, retention, which is ameliorated after treatment. Hematuria is present normally in nutcracker and in bladder or vesical varices. Infertility is well known with varicocele. So now, male impotence. Is it related really? Well, we didn't know exactly, but a lot of our patients have male impotence, which is ameliorated after treatment of pelvic congestion syndrome. And so 5 out of 7 patients had good amelioration. And in the medical literature, there is some phrase here and there. There is nothing fixed, but we can see only one article, the Egyptian article, which correlate the two pathologies and with some H. pylori bacterial infection. So hemorrhoids, you can remember this slide from Bombay. And we noted in females that the existence of hemorrhoid with vulval vein, with lower limb pain, and their radiologic and anatomic correlation, and a lot of pathway of collateral communicating the hemorrhoidal plexus with the pelvic veins, spermatic and internal iliac. And our hemorrhoidal patient, most of them are ameliorated after the treatment. Now, this sciatic pain is typical, also from Bombay. We mentioned that it is a recanalized or repermealized sciatic vein. It is the same case as a recanalized umbilical vein in portal hypertension. And we mentioned that it presents in our cases 6 of pelvic congestion syndrome cases and 7% of all varicose vein cases. It comes from the inferior gluteal normal to sometimes to the sciatic nerve vein, and this one who is causing the most of pain, and so more often to the axial, more superficial vein, and sometimes via the giacomin who communicates with, and finally the marginal subcutaneous vein can come from the superior gluteal artery. So we must look to the origin in the pelvis. And we will present nearly 70 cases of this sciatic vein, permanent sciatic vein. There is some persistent vein, rare, Klebs-Trinoni, pelvic congestion syndrome, and post-Klebtic syndrome. And as you can see here, these veins are completely incontinent. So it can do good stasis, and with the lateral aspect, it passes behind this femoral head, not before. And sure, we must go by the pelvis to treat it, to sclerose the inferior gluteal vein, then going to the small saphenous vein, follow it, we will find this sciatic vein sinking down and down in the rear side, and we will see this vein giving a lot of perforator to rear side component, and it is completely valveless and it is reflecting. So sure, we must look for it. Here you can see here is the lesser saphenous vein, a good junction, continent junction, but a big sciatic vein. Incontinent sciatic vein, sure, we are going to catheterize it and treat it by sclerose, no thermal occlusion, sure. So finally, the urinary lithiasis, it is so normal. It is so normal to find this dilatation, this pelvic urethral dilatation, and here is the point of compression in our pelvis, and we can find also in the renal hill some these signs of compression. Here you can find this atypical left renal vein compromising the hill, and here we can find this big spermatic vein compressing the junction. So finally, let's take a breath with this nice photo from Agenta and Elura Caves that I visited last January, and we will continue with diagnosis. Diagnosis is mostly clinical. Sure, we can use other methods. We always we can ask for scrotal echo Doppler, and with this inspiratory reflux, it is typical, but we are rarely thinking to look for the pelvic varices in the pelvis, not only in the scrotum. So, in the rare case, we should ask for CT or MRI. So now going to treatment indication. Two real indications. The classic one, varicocele plus infertility. It was the classical one. And our new indication, it is unexplained, treatment-resistant, specific symptoms that we have mentioned, plus proven MPCS with ultrasound or CT, etc. How should we treat? Sure, the catheterization, embolization, gluing is the same thing as female. We will not focus on. And we will focus only on special treatment method for occlusive cases as the tips for hypertension and venous recanalization in maternal and post-thrombotic, and the difficult case of nutcracker as our stents in the left iliac vein are compromised between this pulsative clump, and they will crash or immigrate. So we are doing this anastomosis, iliac anastomosis. Other teams are doing the classic dangerous implantations, laparoscopic enveloping, and this very elegant microscopic operation of spermatic and epigastric veins anastomosis under local anesthesia. Why not? So let's see some cases. Our first case, it was our first ever contact with the male pelvic congestion syndrome 2 years ago. So 72 years old man with prostatic hypertrophy, and he has some varicose vein, but normal echodoppler lower limb, and he has bilateral huge varicocele. We discovered. So we are going to embolize it, but looking also for where is the communication with the pelvic varicose veins that we have found. So here we can see for the first time that this communication with the pelvic varicose, with the pelvic varices. And after embolization, he had ameliorated his claudication and he has less prostatic syndrome. Let's go to our second case. Second case is a young man. He has left buttock and side pain and hemorrhoids and marked impotence. So with echo Doppler, he have bilateral varicocele and he have a venous impotence. So let us go and look. Here we can see we have a varicose vein just within the psoas muscle gain, And when we continue to the pelvis, sure we are closing them. And when we are going to the pelvis, we will notice communication with this hemorrhoidal veins, with the hemorrhoidal plexus, and a little communication by obturator to the left lower limb. So after treatment, he has regression of buttock vein and less hemorrhoidal symptoms and net amelioration of erectile function. Our third patient, 53 years, and he has a lot of varicose vein. He has sciatica and lumbar vein, lumbar pain, and he has recurrent hemorrhoids. And we can find bilateral varicose cell and incontinent trunk of greater saphenous vein, and repermealized left sciatic vein refluxing to the small saphenous vein. So let's see this. So here we are, and we are going to look like other side, but more with the communication with hemorrhoids. And here we come with the saphenous anterne, left saphenous anterne. Here we can find communication with sciatic nerve. So the other side also, and after treatment, he have hemorrhoids regression, amelioration of sciatic vein after complementary left sciatic vein ultrasound-guided sclerosis, and we treated. After some months, we treated his varicose vein. The last case, he is 44-year-old Iraqi old man. He has a lot of varicose vein. He has a fourth claudication and has infiltrations. And with echo Doppler, you have left varicocele, truncal and greater saphenous incontinence, and relatively some venous impotence. So we can see that there is two branches of the spermatic vein. One is scrotal, other is pelvic, and here we are going to the scrotal one. And as you can see, we have communication with the other side, varicocele, and here we have also this communication with the pelvic, and here with the femoral vein and with the saphenous vein. So here is the pelvic branch that we are going to close it, to sclerose it, and just after he has a good spermogram after 6 months, but still now a normalization of erectile function and lower limb varicose vein treated after 2 months. So finally, there is no conclusion. It is not a conclusive study. It is just a first study, an appetizer. And we know that male pelvic congestion syndrome is underdiagnosed common male pathology. It is what we must do. So we must believe in it, then work and study and think always about it, and look for in each patient has this symptom, then identify and treat it. And finally, please stay safe and healthy, and many thanks from oldest inhabited capital, my city, Damascus, and thank you very much.
Thank you, Dr. Tarazi, for that wonderful talk. You almost covered everything, and really, it's clap-worthy. We are all sitting far off, but we are all clapping for you. And now, my friend Dennis, it's time to invite you. Welcome, Dennis, with your talk. Please unmute your mic and come with your slides up, case presentation.
So, do you hear me? Do you hear me?
Yes, we can see your screen.
Okay. So, thank you for this invitation. So, honestly, we are not so well experienced as our previous speakers, but I suppose that my case will be interesting, and I'm more interested of the comments of real well-known experts, such as Sriram, who is also here. So I hope that he will give us a very good comments about this case. So Our patient, she was 40 years old, female woman. So she had complaints such as severe pain in pelvis, in standing and sitting position, and also severe dyspnea. So it was really severe symptoms because this patient, she couldn't went to work, and also so she couldn't work at all because the symptoms was really severe. She came to a surgeon and gastroenterologist, urologist, gynecologist, proctologist, neurologist, and nobody couldn't understand what's going on with her symptoms. So we did CT scan in our clinic and found there obstruction of iliac inferior vena cava. So, and as you can obviously see here, there was a huge 15 millimeters in the diameter right ovarian vein, and also big varicosity network in her pelvis, as you can see here. So, as you know, Russia is quite a big country, and we have very big distance. And also in some of our clinics, we cannot put implant big amount of stents. So our tactics, here is another CT scan with these varicosities. So this is her venograms with occlusion of vena cava, and here is this varicosities in her pelvis. So as I started to explain you the situation, it's an organization situation that we had only one stent for her vena cava. So with the organization reasons, we could not implant stents in her iliac veins. So what have we done? So we made the stenting of her inferior vena cava, as you can obviously see here. So we had quite a good result with IVUS, and after 1 month, her pain in the pelvis was disappeared, and there was no dyspnea. So why I think that this case is quite interesting also because it's not so often we can see dyspnea in our patient with IVC syndrome. So after 3 months of stenting, we found a thrombus in her right iliac vein, common iliac vein. But with the organization reason, she lived about 2,000 or 3,000 kilometers from our city. That is why so we found opportunity to make second step of our treatment with stenting of iliac veins only in 10 months. So, as I told you, after 3 months, we found the thrombus. Patient, we prescribed rivaroxaban in 20 milligram per day dose. So, after this finding, we raised the rivaroxaban. So, we prescribed 30 milligrams per day. So, it was our tactic, individual tactic for this case. And we could put stent in her iliac veins only in 10 months after. In 10 months later. So here is the IVUS. You can see thrombus here and the thrombus in venogram. So, and here is her right ovarian vein. We did venography through the stent and found that her ovarian vein diameter was decreased to 7 millimeters, from 15 to 7 millimeters. So we made stenting of her iliac veins, but also only common iliac veins. And I will be very interested of opinion of Sriram that what he thinks about it, because I know that we should put stents in whole iliac veins, but with economical reasons, with organizing reasons, we could not do this, and we put stents only in her common iliac veins. So it was kissing stents here. And here is her final result. As you can see here in her previous venogram, it was big. So also we can see veins here with connection to veins. And in final result, we have very good outflow. And nowadays she has pain in her pelvis, and she has, but she has no dyspnea, so which is very important for us. And we are planning to use coils for her right ovarian vein, but only as the next step, as I told you, because of economical reasons. So, and here is my final slide. So it is her previous CT scan with this right ovarian vein, and now she has a better picture, but still has some pelvic congestion syndrome, but she can work already, and she can, so she's feel quite much better, and her quality of life becomes better. So I hope my case was interesting for you, and nowadays I'm more with this topic. I'm more like student, and I'm really interested of your opinion, and also of opinion of Sriram and other well-known experts of this theme. Thank you for attention.
Thank you very much, Dennis. It was a beautiful presentation you made, and a nice case, lot of hard work. Now it's time to go to the chairperson, Sri Ram. You take over. You're the chairperson, along with your colleague, Sandeep. So over to Sri Ram and Sandeep.
Thank you very much, Deki sir. It's wonderful to be here. Some great presentations. The fact that there are so many different opinions on what should be done for many of the cases does not mean any one person knows it better than the other. But thank you for considering me an expert. It just means none of us know what is exactly the right way to do these things. So if I have a difference of opinion, it doesn't mean I'm right. It just means that I think a little differently, and there's nothing wrong in any of the things that were presented. I first want to congratulate Louis for a very fantastic presentation on male pelvic congestion. And finally, for the association between male pelvic congestion and erectile dysfunction. As you're aware, I do a lot of erectile dysfunction work for venous leak, but we approach it from the dorsal vein of the penis rather than from the top. And most people, and 40% of the patients have varicoceles, and the fertility does tend to improve. So the systems are obviously linked, whether you come in from the testicular vein side or whether you come in from the dorsal vein side. The two systems are obviously linked. My first question is to Loe. I saw the wonderful presentations on the persistent posterior sciatic vein, which is inside the substance of the sciatic nerve. It is the axial vein of the lower limb, or part of the axial vein of the limb bud. And I wanted to ask you, how do you access, I saw you say that there was ultrasound guided foam sclerotherapy of this posterior sciatic vein. How do you access the posterior sciatic vein? Is it from above through the testicular vein connection, or is it some way from below?
No, normally we should begin by treating the origin, the pelvic congestion syndrome, as usual. But the ultrasound guided access is via popliteal approach. Donc you will see your small saphenous vein and follow it up arriving to the knee, there is a lot of variety. I think I've presented this in some talk, but there's a lot of variety here, and you can find this sciatic vein. This sciatic vein. Sometimes it is just a continuation of the smallest vein.
Yes.
But other times, no, it has an hemangioma, and so many times you can catheterize it, and sometimes you are going only with your knee. You cannot put a catheter within. And
Okay.
you should.
So will you then do the venogram from the top, get an idea of the anatomy, and then see how you're going to approach it from below?
Yes, the problem is that it is rarely done in the same session. Normally, dealing with the radiographic part from above, and then going to our clinic or analysis to treat it from below, from below.
It's a wonderful case, because I have seen the post-sciatic vein. I have seen a foam sclerotherapy spill over into someone with a persistent vein. And had to deal with the foot drop because of the sclerosis for 6 months, which came very close to a lawsuit, because when you do foam sclerotherapy of the sciatic vein, which is inside the substance of the sciatic nerve, the risk is you can have some sciatic nerve damage. I've never attempted it again, and I was quite pleased that you can identify it and do it this way, because I'm a little scared to do it. Having had one bad experience, but I don't have a huge amount of experience in it. My other comment and question was to Dennis on the case he presented. Lovely case, Dennis, and I think we've done very well given the circumstances. Just a couple of things for the audience. You mentioned dyspnea. There has been a recent paper that was submitted, I won't say from where, but from somewhere in the US, to phlebology, which I reviewed, and we had to say no to this paper because some of it was not done correctly. But anyway, but it was a case of POTS. It was a series on POTS. Many of you may not know about POTS, which is postural orthostatic tachycardia syndrome. Patients with pelvic congestion have a fairly high association of postural orthostatic tachycardia. And that appears to be because of the pooling of blood. There is an autonomic response and they get tachycardic. And some patients can get tachycardic to the extent that they're essentially developing a degree of high output cardiac failure, leading to dyspnea. So that may well be the reason why, after you have treated the pelvic congestion, or at least slowed it down, that the dyspnea has improved. Having recognized this, we are now beginning to do tilt table testing in patients who present with fatigue and dizziness and fainting and pelvic congestion, on whether they have a POTS type syndrome, because you can identify it by tilt table testing. And a comment to you, isolated IVC stenting. If the bottom end of the stent is in the caval confluence, which is where your bottom stent end was, when you do a venogram, you can actually see from either iliac vein that only a portion of the IVC lower down gets opacified, because there is a strange, it's not quite laminar, but columnar flow that takes place at the confluence. And it's only further up that you see the whole IVC. So there's a lot of flow turbulence at the confluence. So if you're going to stent up to the confluence, then you will need to extend it into the iliac veins. Otherwise, there's very early thrombosis at that site. This is different. You can do isolated iliac stenting if you're doing an iliac vein web, which may be higher up, or retrohepatic, and you do only an iliac vein isolated stent. That is okay. But if for some reason the stent is coming down to the bifurcation and is sitting on the bifurcation where the iliac veins meet the IVC, then you nearly always have to extend the stent into the iliac vein. Otherwise, there is a risk of early thrombosis, which I think is what you've seen. So that was my comment. I look forward to others. I mean, I have so much wonderful stuff that I've learned in this meeting and this presentation that I could go on, but it's time for others to speak, and I will come in as and when I can. But thank you. Sandeep, something
Yeah, sir.
Yeah.
to
Comments
say
from
as
Sandeep.
chairperson?
Thank you, Professor Sriram, Professor Lee, and Dr. Dennis. Nice talks by both of you. And Dr. Birend, I think he has left the meeting. So, firstly, Dr. Louis Vijay, I would like to ask Dennis. Dennis, are you hearing? Your mic, I think, yeah, muted.
Yes.
Hi, Dennis. Congratulations for getting vaccine in your country from today. And so, you mentioned about dyspnea. I think she must be also complaining dyspareunia, pain during intercourse.
No. I talk about dyspnea means she could not
Shortness of breath.
breathe. Not
Yes.
Yeah.
breathe.
So she was not having dyspareunia.
No. She
So
had
no, like I do less intervention to these cases because maybe many cases gynecologists they do the oophorectomy and hysterectomy. So one common question. So apart from this embolization, do you advise these patients some pelvic exercises apart from walking, running, cycling, and swimming? Any specific pelvic exercise?
No.
Nothing. So another question to Dr. Louis. Hello, Dr. Louis. No, because
Yes.
he's a very senior, so he might embolize so many cases. As per the literature, there is 5 to 8% recurrence. So in his practice, how often do he get recurrence pelvic congestion syndrome after embolization? Any experience with Dennis?
Yes, for the recurrent pelvic congestion syndrome.
Yeah.
Are you asking? Yes, we have seen in our first experience. I am treating pelvic congestion syndrome since 20 years now, and more than 1,000 cases. So in cases we tried the coils. We tried coils, but with
re-embolization. Okay.
You have
so,
you will have some recurrence everywhere.
And so do you sometimes treat like pelvic congestion with varicose vein? It's common in many patients both. So you treat them in the same sitting or different sittings?
No, normally in the different session. Normally I'm treating them in the different session. I am treating, I need fluoroscopy for pelvic congestion syndrome. The other are in our clinic with other sessions. And there is often a lot of regression of our limbs, varicose veins. So you need less treatment, less sclerosing agent. So treat just from above and wait. But the real question is, should we treat both always? Sometimes with the mild pelvic cases, maybe treating only the lower limbs varicose vein can be enough.
Okay. Like sometimes I have treated varicocele and varicose veins together in the same sitting, few cases.
Yeah.
Okay, so I'd like now to pass the mic to Professor Sriram and Professor Deki.
Yeah, so now with the chairpersons, thank you for your interaction and continuing the subject. It's time for our panelists, Dr. Vimalin and Dr. Lau Luthra, for their expert comments in this.
Yeah, good evening, everyone. All the three speakers, thank you so much for the wonderful and such an informative talk. I just had one question. I just wanted one clarification regarding the role of flavonoids or drugs that improve the venous stones. Do they have any role in treating the pelvic congestion syndromes? Today's talk, we've heard a lot about the endovascular embolizations, but either patients who are not ready for the embolizations or they are not willing for the embolizations, is there any medical management? Like, is there any role of antiplatelets like ecosprin in conservatively managing this disease? And second question is, is there any role of flavonoids in the post-embolization period to prevent the recurrence?
Dr. Louis, do you want to go?
Yes, maybe yes. Yes, sure. In the mild cases, we are not going to operate them anyhow, even not doing phlebography. The mild cases we are treating with medical treatment, including flavonoid, And sure, and some hormones, more progesterones, maybe some sedative, and some psychiatric treatment. These guys need, even the males that I have, I know the females, we have a lot of psychiatric approach of this woman. You must be friend of them a lot, because you will need them during the operation to do a lot of Valsalva, and you will need to explain to them everything. If not, they will not have confidence in you, and they will not never ameliorate. So psychiatric support is a good part of the medical treatment.
Can I just comment on that? We have some early data on this. We should be publishing soon too, on the role of flavonoids. The answer to that is yes. In fact, we have seen now people who talk about the symptoms of pelvic congestion. It is important to tell patients that they don't settle down the day after the procedure is done. It takes about 2 or 3 cycles before the symptoms really come under control. It doesn't happen, the first day afterwards. But we have found, and we've moved to a regime where instead of giving 500 milligrams twice a day or 1 gram a day of Daflon, we are giving now 2 grams of Daflon for the first month. So this is the hemorrhoidal dose. So we would give 1 gram twice a day for the first month, and then 1 gram a day for the next 2 months for a period, so a total period of 3 months, but a higher dose for the first month. And there is no doubt, and we will publish that data soon, that the time for symptoms to resolve post-procedure is certainly less if you sort of load them up with a higher dose of Daflon in the first month. So yes, flavonoids do have a role to play. I'm not aware of the role of any antiplatelet agents like Ecosprin. There's certainly a role for pain-killing doses of NSAIDs, but then they are being used as painkillers for people with pelvic congestion. Would there be any other questions?
Yeah, just thank you, Dr. Sriram, for chairing the session. And thank you, Dr. Dennis, Dr. Louis, and Dr. Virendra for excellent presentations. I have a few comments to make. Number one is, the problem with pelvic congestion is our understanding is so poor, and unless we have a highly specialized practice, it's very difficult to actually say what's right and what's wrong. And in this regard, I think the Indian Journal of Vascular Surgery has a couple of very good articles written by the Whitley Clinic talking about diagnosis and treatment and what are the other options available in pelvic congestion. My question is to Dr. Louis. I remember the part where you had gone through the diagnostic methods, and most of which was based on a venogram. Do you use a translabial, transvaginal, and a transabdominal ultrasound, or do you just stick to the venogram with the transabdominal ultrasound?
Yes, no, venogram is only the first part of the treatment. We never do venogram just for diagnostic. You can find everything with your ultrasound, with your transvaginal ultrasound, with MRI, CT, but we don't do venogram just for diagnostic. Venogram is just the first step of the treatment.
Further to that, because it's more of a static picture in a venogram, and you're never able to actually achieve, a more physiological position of putting a patient up to almost 80 degrees in a venogram. And CT and MRI also, there is the same problem of the patient being parallel to the ground, and whether you're actually able to see all the reflex. This is all theoretical. In your practice, what do you feel about these statements that are made in the expert community?
No, sure. Begin with ultrasounds. If you can find the answer with ultrasound, it's all. If not, you must have your CT. But it must be very specialized CT, because the renal vein and the ovarian vein refluxing, they fill in the arterial phase and not in the venous phase. In the late arterial phase, So you must go with the technician, explain for them to do their section under Valsalva first at the late arterial phase, then returning by the venous phase. And after you can see everything, I think.
Can I just comment on that, Vimalin? I know there was some reference to the Holstock criteria, which was developed by Judy Holstock at the Whiteley Clinic. There has been a paper that came out last year by Nicola Bropoulos as well, and we do a very large number of transvaginal ultrasounds, and some criteria that people have to understand. It is not just being able to see a bunch of varicosities filling. The transvaginal transabdominal duplex has a very specific role on the diagnostics and the significance of the pelvic congestion. It is done in two parts. It is done with the patient first sitting up at 45 degrees. It is then done in the second part with the patient lying down. The first part is also done with the bladder full. The second part is then done with the bladder empty. So the patient essentially fills their bladder and then is sitting up in a sort of stirrupy position at 45 degrees when we begin the transvaginal transabdominal ultrasound. So first you do the transabdominal part. In that 45-degree angle from the lateral side, you will be able to see the dilatation and the reflux down the ovarian vein. That is the purpose of the abdominal part. You cannot see the lower part of the ovarian vein if the bladder is not empty. If the bladder is not full, if the bladder is empty, you're unable to see it. So after that is done, we then empty the bladder and bring the patient back. The first part is then again done at 45 degrees. So what do you do at 45 degrees in the transvaginal? You're looking for some very specific things. One, you're looking for reversal of flow in the internal iliac vein. This is key. If the internal iliac vein flow is reversed from the iliac side into the pelvis, there is very likely and common iliac vein compression. So this is a pelvic congestion syndrome secondary to an NIVL, as opposed to a pelvic congestion syndrome secondary to an ovarian reflux, because you will get ovarian vein dilatation even in an internal iliac venous reflux. Remember, internal iliac vein, parametrial veins, ovarian vein, it is the internal iliac uterine ovarian venous axis. So it will dilate backwards. So you're looking for first reversal of flow. Second, you're looking for loss of phasicity in the internal iliac vein flow. As Nick Labropoulos showed, the presence of phasicity does not rule out obstruction, but the absence of phasicity is diagnostic of an outflow obstruction. So that is the second thing that we're looking for. The third thing we're looking for is speed of flow in the varicosities. Is it less than 3 centimeters per second or not? That is number 3. The fourth thing you're looking for is the size of the ovarian venous diameter. Some would say 5 mm, some would say 6 mm. But we IVUS everybody during the procedure, right down into the iliac vein, up into the IVC, into the renal vein, and back down into the ovarian vein. The IVUS travels beautifully. We have found time and again that the ultrasound diagnosis of venous size of the ovarian vein, 6 mm or 7 mm, is often incorrect. You will often find 11, 12 mm on an IVUS. And that is a dangerous thing to measure your coil or your plug purely on the size that you think it is. Because especially if these women go on to get pregnant again, the ovarian vein will dilate and an already small coil will come loose and you can fish it out. Call Dr. Bedi to fish it out of the right heart. That is where it's going to be. So we are a bit careful about that. So the criteria for transvaginal duplex are fairly well written now. There is an American Venous and Lymphatic Society set of criteria on it. But remember these 4 key things: ovarian vein size, reversal of internal iliac flow, loss of internal iliac phasicity, and the presence of a 3 centimeter or less or a slow flow system in the pelvic varicosities. These are the 4 transvaginal duplex criteria to say, yes, this is significant pelvic congestion syndrome. It is not a trial and error anymore.
There are a few comments from the people who are attending the webinar. So I'll just go through them. One of them is, could any of the speakers, panelists highlight important clinical aspects which should lead to a high index of suspicion with regards to PCS as a cause of hemorrhoids? So you want to answer that?
I can answer it.
Yes.
I can answer it.
Yes, Dr. Louis. Yes, Doctor.
Yes, yes. So normally hemorrhoids can be a part of the pelvic congestion syndrome in male and in females, and apparently more in males, apparently more in males. So sure, in every hemorrhoid patient, look at the pelvis, look at the testicle, look at the reflux, look at the PCS in every hemorrhoidal patient. So, because if not, you will treat the hemorrhoids and you will have recurrent hemorrhoids everywhere. So, I am not saying that all hemorrhoids coming from the pelvis. No, it is one of the main causes of the hemorrhoids.
Well, I have one question for Dr. Tarazi. You mentioned about H. pylori infection. Can you highlight more on that? What type and the effect on pelvic congestion?
No, it is just when I have my patient with impotence, male impotence, I looked in the medical literature if there is any relation between pelvic congestion syndrome and erectile function. And I found only one article, Egyptian article from Mansoura, which relate both, and they said that they are related to some H. pylori genitourinary infection. But it is just one article. But I mention it because it is the only ever article that related both. But I don't know personally, I have no experience.
There's one question from Preeti Sharma to everyone. If a female childbearing age has been treated for PCS by intervention, how long would you suggest she should wait for the next pregnancy?
Can I take that? Dr. Dickey, this is a very good question. In fact, I've actually sent back privately to Preeti that I will answer this in a minute. And this is a very important part of decision making for people with ovarian venous reflux. The reason for this is that a pregnancy can lead to an 18 to 20 time increase in venous outflow in the ovarian veins. And so the ovarian veins will normally dilate to even 12, 15, 18 millimeters during a pregnancy as the pregnancy progresses. So your 8 and 10 millimeter coil is going to come loose. And I can see Dr. Bedi sitting there now, and you will have to call him to take it out of the right heart. That is where it will be. So our decision making has really changed. So the question, how long should she wait? Let me begin by saying, firstly, if there's a lady who's either planning a pregnancy or likely to have a pregnancy, and if you ask her, are you planning any more children? She says, I don't know, it may happen. If she even looks unsure that she may be having babies in the future or is planning to have babies in the future, my honest, strong opinion is, and this is an opinion, is that you should not coil this patient. You can do perfectly well balloon-controlled foam sclerotherapy. Yeah, it's a straightforward 5 French Fogarty balloon. You pass the Fogarty balloon down as low as you can before the bifurcation of the ovarian veins begins. Open the balloon and you inject the sclerosant through it so that the sclerosant does not travel up. You can do a dual balloon control technique if people have a large amount of myometrial cross circulation in the pelvis. So on the right side, you pass a standard venous angioplasty balloon and sit it where the internal iliac vein comes off. So you're blocking both outflows essentially. Something to be careful here, if there is on your first venography, there's a large filling of the iliolumbar vein, please do not sclerose. There have been cases, and there's actually a lawsuit in London that happened from one of our esteemed colleagues. Nobody's fault, we didn't know this could happen, is that some sclerosant actually went up in the iliolumbar vein towards the spinal cord, and there was a period of paraparesis. So this is avoidable, but it's not that common. So if you think somebody is going to get pregnant or planning to get pregnant, please try not to leave implants and use sclerosants. Yes, the recurrence rate is high. The recurrence rate is well in excess of 20% or so, somewhere between 20 and 30%, we think. But that's okay. You at least alleviate the symptoms and temporize the measure until the pregnancy. The pregnancy is not affected. On the other hand, if you're pretty sure that they're not going to have a pregnancy, then you can go ahead and do an embolization. I am aware that there is a publication of people who have had embolization and then gone on to have pregnancies, and the suggestion is that nothing really goes wrong. It is from the Whiteley Clinic. I have seen that paper as well. I just feel a little uncomfortable having seen the size to which the ovarian veins can go during a pregnancy. So this is my personal view.
I have one thing to ask, Ram, to you.
Yes.
A coil is sitting in the ovarian vein before pregnancy. It is fixed there. It has given results to your pelvic congestion reflux going on. Now, if the lady becomes pregnant and the vein dilates, how is that coil going to fly off back? They get fixed.
No, actually, the coils don't get fixed. The mechanism, by which a coil acts is by slowing down the flow and creating a thrombosis. The coil is not fixed by bar.
We'll have to allow Rahul. Rahul is coming in. Yes, Rahul.
Coils out from the veins before, and in whichever vessels you put in the coil, everything becomes so fibrous because coils work because it creates a lot of inflammation around. So once your vein becomes totally fibrosed and everything because of the inflammation, because you don't only put in coils, you also put in a sclerosant along with it. Once it blocks, it becomes fibrous. I don't think, and I haven't ever read it, that if you have coils in the veins and you have sclerosed it, and then the pregnancy becomes, and the vein will respond to the hormones, and then the veins will dilate. Unless you have read some report like this,
there are case reports, which is the only reason. I agree with you that
from the IVC, maybe yes, not from the ovarian vein. I haven't read it. Okay.
Oh no. Ovarian vein, renal vein stents, all of these have been taken. Now, I agree with you that this may not be a very common occurrence. I agree with you on that. But I'm just a little uncomfortable.
One at a time, please. Yeah.
Okay. I'm just a little uncomfortable in a litigious environment because the consequences of this are very hard to protect. And if I can temporize it, this is my personal view. There's no huge amount of data one way or the other.
No, sure. I think what we can do is, we always use a combination of agents. So, I'm doing it. If they are there, we are using glue, we are using coils, we are using, foams. And, with my experience, like we are not putting the coils in the first 10 centimeters of the ovarian vein. I'm not doing it now. So I'm just putting in the coils quite deep in. And in the ones I do the pelvis so that the coils does not come hanging into the renal veins, or sometimes you slip off with a high flow. So, or put in the plugs, big plugs, which will, totally get fixed up. And, but I haven't come across stents. I know stents, they migrate because stents, they open the vessel and with the flow, they can migrate. But, coils from the ovarian vein, I haven't read it, but I'll go through it. There is a case report published on this,
Maybe I just don't have the guts. And as but I'm a bit conservative. I'm a bit scared. But I'm sure it's possible.
What I'm saying
there is a paper from Whiteley Clinic that says that nothing happens. That is there. That is definitely there. But I just don't have the courage.
Well, friends, Rahul, it's time is getting on. Should we continue or?
So we should stop now.
Yeah.
I
have few things. The topic has been discussed thoroughly well, but yet there are few things to be addressed. The Lever-Training syndrome, the proctalgia fugax, and the perineal pain, the perineal ultrasonography in male. Maybe transrectal ultrasonography is under study for the male pelvic congestion syndrome. I don't know. But the topic is a hot one, as hot as the pelvis itself is. And I think we should all come together and
Save your pelvis for some good things.
write down our own literature with people from all around the globe, and let us meet again with this. With this, I wish my sincere thanks to Dr. Virender, Dr. Tarazi,
Thank you.
from Dennis, from Sriram, from Sandeep, and our panelist Bimalin and Love Luthra. It had been a great time with all of you, and wish you happy times. Hope to see you soon again for this wonderful meeting. And my sincere thanks to the Sardia Pharmaceuticals for creating such a wonderful platform. I don't think that during conferences, at a time 70 people keep on listening for 1 hour over a topic, which on this platform becomes possible. Thank you and bye-bye.
Thank you very much. Bye-bye.
Thank you.
Thank you.
Thank you, friends, and we'll see you next Wednesday. Same time,
Okay.
next Wednesday.